How's it going? So we're going to be doing something quite different today. We're going to be doing a pre-test walkthrough. So for the ITLS Advanced 9th edition, we're going to be going through each and every question of the pre-test. The pre-test and the answers are all online if you search hard enough. But the point of this is so that we can turn it into an educational tool. So we'll talk about each question, we'll talk about the potential answers, and then what the literature and the textbook are saying about the answer. So if you are someone who's going to be doing their ITLS or just wants to learn something new, this will be just right for you. So let's get straight in. So question number 1. In a rear impact motor vehicle collision, which area of the spine is most susceptible to injury? So without even looking at the answers, which part of the spine is most likely to be damaged in an injury? It's most likely the part of the spine that moves the most. So the spine is, broken up into, in simple terms, the top bit, the middle bit, and the bottom bit. So really the cervical, which is the top bit of your spine, where if you were to get hit by a car, your whole head's going to move forwards like this, or backwards. There you're going to have more movement of the spine. You're less likely to have a thoracic spinal injury than you are to have a cervical, because that's the bit that I'm using to move my head around. So that would be the answer for number 1. Question number 2. A 36-year-old male sustains blunt force thoracic trauma and fits the criteria for a load and go patient. Which of the following should be performed on scene? So ITLS is pretty strong on pushing what we should be doing and what we shouldn't be doing on scene. They're very much not wanting us to be putting up IV lines. They're not wanting us to be, like splinting and making things look all pretty and doing unnecessary things on scene. We're wanting to get the patient into ambulance and go to hospital. So without even looking at the options, I can say, we are either wanting to treat life-threatening injuries, find life-threatening injuries, or get to hospital. So what are the options? Obtain an ECG, establish IV line, no. Obtain finger stick serum lactate, no. Or assess for other potential life-threatening conditions. I'll go with D. We need to assess for other life-threatening conditions. That's why they have the rapid trauma survey. Question 3. The use of external laryngeal manipulation. Why do we use that? Well, what is it? It's when you pretty much put some sort of pressure onto your larynx to increase the view of your intubation. We don't use cricoid pressure. It's not the same as cricoid pressure. You might have heard of burp, so backwards, upwards, right pressure. That is a type of external laryngeal manipulation. And so what are the potential questions or possible answers, So decrease the risk of airway trauma, no. Reduce gastric distension, no. Improve glottic visualization, I would say yes. Causes aspiration, no. So I would say 3C, and that is correct. Question 4. A pericardiocentesis is performed to? Well, a pericardial centesis is the pericardium, the sac around the heart, and centesis is to stick a needle in it. So to remove fluid from the sac around the heart. This could be due to trauma or medical reasons. Question 4. To remove fluid from the lining around the lungs? No. To remove fluid lining around the heart? Yes. To inject medication directly into the heart? No, it's not Grey's Anatomy. To monitor stroke volume? No, it's not a monitor. You could put that into a central line, not straight into the sac around the heart. So yes, it would be B, to remove fluid from around the heart. That's question 4. B, that's correct. So interestingly, a traumatic pericardial tamponade, the treatment is not a pericardiocentesis. It's not going to fix the problem. 1, trying to draw blood out of the sac generally causes clots and generally clots up the needle, so it is actually not indicated. The other issue is that there is a bleed. It is bleeding, which means the bleeding has to be stopped, which can only be done if you crack the check. And interestingly, they actually mention that what is recommended is a front clamshell crack, not going left window, because left window only allows you to see the left-hand side, and you have to use your hands to feel. So clamshell front is indicated. Not that that's part of our scope. Question number 5. A 56-year-old male sustains a gunshot wound to the abdomen. Vital signs are blood pressure 74/32. Pulse, pulse present only at the carotid, and a respiratory rate of 24 and shallow. The target of fluid resuscitation is? So he has a gunshot wound to the abdomen, so he will be bleeding. He is got a low blood pressure. He is too low, and his pulse is increased. So we want to do something called permissive hypotension. So what that means is that we're wanting to allow a low blood pressure without pushing it too high, so that we can have perfusion of the heart and the brain and the kidneys and the gut and all those little things, but not push too high so that we then blow clots out. So we used to just pour fluid into these people, but not anymore. So I would say that we want to give fluid until we have a peripheral pulse, or fluid until we have a MAP of 65 or a systolic of 90. Not that these numbers are proven or anything like that. So A, return of peripheral pulses, so we have signs of good perfusion. A shock index, which is also a very interesting concept, is a way of assessing for severe shock. So shock index, which pretty much summed up is that if your heart rate is above your systolic, there's a problem. Question number 6. An unconscious 15-year-old male was struck on the head with a baseball bat. His arm and leg are extended and his right pupil is dilated and fixed. You should. So he's been struck in the head with a baseball bat and his arms and legs are extended. So I guess like decorticate or decerebrate sort of thing. If they're extended, which is decorticate, obviously real brain damage there going on, and the right pupil is dilated and fixed. So we probably have a bleed in the brain. Insert an oral pharyngeal airway, administer oxygen and restrict fluids, apply a non-rebreather mask, restrict fluids and administer mannitol, perform nasotracheal intubation, restrict fluids and provide adequate ventilation, perform bag valve mask at a rate of 20 per minute. So there are signs that he is potentially herniating. This would be due to the extension of his arms and his legs and the blown pupil. So if someone is herniating, you can indeed hyperventilate. So by hyperventilating, what we do is we blow off more carbon dioxide, which actually causes vasoconstriction in the brain. This then decreases the amount of blood getting into the brain, which we are assuming will then decrease the pressure in the brain. So the brain is a closed system, which is the spinal fluid, the brain matter and the blood. And so if we constrict how much blood is getting in there, we then decrease how much pressure there is. So I would assume that we're going to perform a bag valve mask ventilation at 20 per minute because there are signs of him coning. The other ones don't necessarily make any sense. Question 7. Which of the following mechanism of injury does not commonly cause damage to the spinal cord? Hyperextension, hyperflexion, lateral stress, or compression. Which of the following mechanism does not commonly cause? So what does not commonly cause damage to the spine is in fact lateral stress. Like I said, when we have this movement to the left or to the right, is not commonly going to cause spinal injury. So if you have a car and you get hit by the side, so you have a side impact on a car, you're unlikely to have spinal cord damage because you have this movement of the spine left and right, not necessarily parts of the spine, where compression and flexion, hyperflexion, or hyperextension is more likely to cause more damage because you have that bending of the spine. Question 8. A 4-year-old female is unconscious after falling off a bicycle. Which of the following is the best method to open the airway? So 4-year-old child, trauma, we can't do a head tilt, chin lift, we have to do a jaw thrust. Modified jaw thrust, head tilt, head flex, or neck flex, neck lift. We have to obviously do a modified jaw thrust. This is done by, it's hard for me to demonstrate, but you pretty much put your thumbs over the patient's cheeks and you lift the jaw with your index finger. Question 9. When performing the ITLS primary survey, the team leader may minimize errors by A. Performing all interventions, B. Limiting crew roles, C. Permitting crew to continue the assessment, D. Delegating interventions. So we are able to minimize issues if we delegate tasks. So if we're getting other people to do the things that we can't necessarily do, or if we don't have enough hands, we are less likely to make mistakes if we delegate tasks to our team. Pretty straightforward, I think. Number 10, you have placed an NPA, so nasopharyngeal area, in your patient and now observe mild hemorrhage from the nares. You should. So if you put a nasogastric in, I've made a video about that at the top. I'll put a link. If there's bleeding, I probably wouldn't do anything as long as there's not massive bleeding. A, immediately remove the NPA and pack the nose with gauze. No. Immediately remove the NPA and reinsert in the opposite nair. No. Leave the NPA in place so as to not disturb the clot or reactivate the bleeding. I would probably say that. And C, 10D, contact medical control as an NPA will not cause hemorrhage. C, leave it in, probably very mild. I don't think that nasopharyngeal areas are necessarily the most helpful or important. They do not maintain an airway. It only increases the space for air to move through the nose. It doesn't actually lift the tongue, like an OPM. Question 11. A 27-year-old male with blunt chest trauma from a motor vehicle collision was successfully intubated at the scene. While ventilating the patient, you note resistance with absence of right chest wall movement. You should suspect. So in terms, I would assume maybe a tension pneumo. If you have a ventilated patient who has a potential tension pneumothorax, we're going to have increased ventilation pressure and rapid desaturation. We're not going to see tracheal deviation or hyperresonance or all these other things, or whatever, JVD. The things we're going to see is increased ventilation pressure and decreased saturation. So what are the options? Flail chest, gastric distension, mucosal obstruction, or tension pneumo. 11D, tension pneumo. So a tension pneumo is diagnosed with absent air movement on one side. We will see a patient who is intubated will have increased ventilation pressures, so we'll have high pressures on the alarm, which will be alarming, and we'll have rapid desaturation. The new evidence is saying that we're not going to see tracheal deviation, JVD, all these things that we used to be told that we would see. I've also made a video about this. Check it out. All right, so number 12. A 34-year-old man has a gunshot wound to the right groin area. Arterial bleeding, which cannot be controlled with direct pressure or tourniquet, is coming from the wound. The patient appears confused, diaphoretic, and has a weak peripheral pulse. Sounds like he's in shock. He's confused, diaphoretic, and has a weak peripheral pulse. What is the appropriate fluid resuscitation regime for this patient? So this patient is in shock. This patient is losing blood, and they say that they cannot control the bleeding. So it's a patient who's hypovolemic and you can't stop the bleeding, so we don't want to fluid overload them. We're wanting to maintain perfusion. So we're going to be going for something like permissive hypotension. So let's see what they say. Answer A, intravenous fluid at keep open rate. No, we don't want to just keep a vein open. We need to give some fluids. Intravenous fluid, give enough fluid to maintain peripheral pulses. Yes, so we want a peripheral pulse because that kind of gives an indicator of perfusion. C, intravenous fluid as wide open. No, we don't want to just flood them with more fluids. You're going to cause more bleeding. More fluid makes them cold, makes them clot less, blows away clots where that have been formed, dilutes the hemoglobin, it dilutes the clotting factors. D, no intravenous access should be established in the situation. Well, no, he is confused, he's diaphoretic and has a weak peripheral pulse. So he is confused, he is in shock, he has an arterial bleed. So we need to give some fluids, but not all the fluids. We need to maintain a systolic of 90 or a MAP of 65, that would be appropriate. So, cool, question 12. Question 13, the gold standard to confirm that the endotracheal tube is in place, or is placed in the trachea is, well, capnography would be what I would say. So 13, A, evaluate breath sounds, not always accurate. The tube might be in the stomach and they can still be breathing. Equal rise and fall of the chest, the tube may be in the right stream bronchi. You can still not accurate. C, away from capnography. The answer, presence of condensation in the tube, also not accurate. Any sort of heat can cause condensation in the tube. So C, 13C. Question 14. Which of the causes of pediatric injuries listed below is most likely to result in severe injury or death? Children fall a lot. So A, falls, B, motor vehicle collisions, no. C, burns, D, animal bites. The answer would be A, 14A. Children are very likely to fall. They fall a lot. And if you have a kid, they fall all the time, especially when they're learning to walk like my own. Question 15. Which of the following injuries would change a trauma patient's transport classification from stable to load and go? So ITLS is very big on, as soon as we have assessed the patient, we make a decision on whether this is stable, we have time, or if this is a load and go because the patient is going to die and we need to get to hospital. I would probably say a pelvic fracture because you can bleed a lot into your pelvis. So your femurs, you can bleed like a liter or so. Your pelvis, you can bleed a liter or so. That will put you into severe shock. So question 16, which of the following findings would not make a patient difficult to ventilate with a bag valve mask? So what will not make it hard to ventilate? What does make it hard is old people, people who are very thin, if they have their dentures out, people with big beards, lots of blood, that sort of thing. So A is beard, that does make it difficult. B, obesity. That can also make it quite difficult to ventilate because their airway anatomy is different. It's a lot more tissue. C, elderly patient, can be difficult to ventilate. D, multiple nose piercings. Nose piercings have no effect on bag valve ventilation, they can be removed. Question 17. What is the most frequent cause of intubated trauma patients to develop poor lung compliance while being ventilated? So what is going to cause a traumatic patient who's intubated to develop poor lung compliance, so difficult to ventilate? Like I said earlier, a very common thing for someone to go from not being hard to ventilate to being hard to ventilate in a trauma patient is a tension pneumothorax. It is the thing we're going to see in a ventilated patient. So tracheal extubation is not going to give them poor lung compliance. So lung compliance is the ability of the lungs to stretch. Pericardial tamponade, nothing to do with the lungs. Gastric distension, that can cause poor lung compliance, but they're asking for the most frequent cause of lung compliance, and I would say probably a tension pneumothorax, because if you have a tension pneumothorax, you're not going to be able to ventilate. It's going to make your life pretty hard. So 17D. Question 18. Hemostatic agents applied directly to the source of bleeding must be used in conjunction with. So hemostatic agents, they cause clots. So you push them into the wound and it causes an artificial clot in the wound. I would assume and go say that you need to apply it with pressure. Direct pressure to the wound is A. B. Tourniquet proximal to the wound. No, you don't have to use a tourniquet. Pressure points to arteries proximal to the wound. No, you don't have to. Because what if you have a gunshot abdomen? You can't apply pressure points to the abdomen. Or D, elevation of the wound above the level of the heart? No. So the answer is direct pressure to the wound. So when you apply a hemostatic agent, you need to actually push into the wound onto the agent to allow the agent to function. Question 19. Routine use of hyperventilation in a traumatic brain injury. Patient will A, which is what we discussed. When you hyperventilate a patient, it causes more blow off of CO2, which causes vasoconstriction in the brain. So it will cause vasoconstriction and increased cerebral ischemia. Yes, because less blood getting to the brain causes tissue to not have enough oxygen, which causes ischemia. Cause vasodilation and decreased intracranial pressure? No. Causes an increase of end-tidal CO2? It will decrease your EtCO2. Causes peripheral hypoxia and cyanosis? It will not. It will increase the amount of oxygen. You will have hyperoxia. 19A. Question 20. Which finding requires interruption of the ITLS primary survey? So like we had discussed about the whole ITLS primary survey, rapid trauma survey, what is going to stop this process? So cardiac arrest, tension pneumothorax, stuff that we have to stop and fix. So it's the only times when we're going to stop the process to fix something. Would require interruption of the primary ITLS survey, complete airway obstruction, a gasping respirations, impaled object in abdomen, or very weak pulse. So a complete obstruction to the airway would mean you would need to stop what you're doing to fix the airway. You can't continue to doing anything else if you don't fix the airway. We would obviously first check for catastrophic bleeding and then fix the airway. Question 21, almost halfway. Bag valve mask ventilation rarely cause gastric distension due to low airway pressures. No, we often cause gastric distension because we put too much pressure and that causes the stomach to open. Is more effective in patients whose dentures have been removed? No, dentures should be left in. Is easily accomplished by one rescuer at the head? No. BVM is a two-person technique. You should be doing double CE grips or penile eminence or double thumb technique. Or D, may exceed 60 centimeters of pressure in the airway. I would go with D. We can easily exceed 60 centimeters of pressure, which is the pressure that the valve pops off, which is far beyond what the lungs need and far beyond what is needed to open up the esophagus to put air in the stomach. 22. Which of the following is true regarding pulmonary contusion? Pulmonary contusion is just a trauma to the lung that causes bruising. So a contusion is a bruise, so lung bruising, or a blunt chest trauma, I guess. So A, it is uncommon in chest trauma. It is quite common. It is caused by hemorrhage in the lung parenchyma, which is the little like blood vessels surrounding the lung. So it is a bruise or a hematoma or a contusion is bleeding under the skin. So probably B. C, it is only caused by blunt force trauma. No, not necessarily. D, it rapidly develops after injury. No, it can take a bit of time. So 22B is it is caused by hemorrhage into the lung tissue, parenchyma. Question 23. A 25-year-old female was stabbed in the left arm. She presents with an altered mental status. Signs of shock bleeding is controlled by direct pressure and use of a tourniquet. Which intravenous fluid therapy is appropriate? A 25-year-old female stabbed left arm. She presents altered mental status. Signs of shock bleeding is controlled, direct pressure. So the bleeding is controlled. So that's important. So we can give fluids. Which therapy is appropriate? Estimated blood loss and administer fluid at a 3-to-1 ratio. No, it's very hard to estimate blood loss. We're not good at it. Take a liter of water and pour it on the floor and look at what it looks like. You can't estimate. Fluid administration of 250 mils, that's not enough. Fluid administration to maintain a systolic pressure of 60, that's not high enough. Intravenous fluid administration, a bolus of 500 mils, then reassess. We're wanting to give boluses and then reassess and bolus and reassess rather than just dumping a liter or two. So 23D. Question 24. In the absence of herniation syndrome, so someone who's not herniating, adult patients with suspected traumatic brain injury should be ventilated at a rate of. So how should we ventilate patients who have a traumatic brain injury but are not herniating? So 8 to 10, which is pretty normal. 12 to 14, a little bit elevated. 16 to 18, quite high. 20 to 22 is too high. So 10, which is 8 to 10. We kind of want to aim for 10, so 8 to 10 would be within normal range. Question 25, halfway. What is the most likely cause of unequal pupils in a patient whose mental status is altered due to head injury? So with a head injury, what's more likely to cause a pupil that is dilated or not equal to the other is most likely a traumatic brain injury or some sort of herniation in the brain, which is increased intracranial pressure. So 25A is increased intracranial pressure, which is what I said. B, pre-existing conditions. No, not really. Most likely cause in mental status altered due to head injury. Alcoholic intoxication is not going to cause unequal pupils, and hypertension is not going to do that either. So 25A. Increased ICP. Question 26. A 57-year-old male has a respiratory rate of 36, ETCO2 of 30, and an oxygen saturation of 80%. Coach the patient to slow his breathing as an ETCO2 level indicates hyperventilation. No, ETCO2 is normal. Because he's breathing fast, capnography is low, and his saturation is low, I would assume that he's in shock. So a low ETCO2 actually is a sign of shock, so especially in trauma. So a low ETCO2 is a sign of shock. Don't start slowing your ventilations. Fix the shock. Ventilating someone quickly or with more volume only is going to increase their ventilation, not their oxygenation. He has decreased oxygen, so we need to either increase our PEEP or we need to give supplementary oxygen, which is 26D. Question number 27. A 31-year-old female presents with difficulty breathing, rapid, weak pulse, flat neck veins, midline trachea. Your assessment on the left side of the chest reveals decreased sound and dullness to percussion. You should suspect. So tracheal deviation actually doesn't mean anything because it doesn't happens super rarely and very hard to assess. So the difficulty breathing, rapid, weak pulse, flat neck, so no JVD. What do we think is happening? It doesn't tell us what trauma has happened, but she has flat neck veins, so there's no increased pressure in the chest or the heart. So we're not going to think a tension and we're not going to think a tamponade. So what are the options? A, tamponade, no. B, flailed chest, no, because that you're going to see and feel. Tension pneumo or massive hemothorax. I'm going to go with 27D, which is a massive hemothorax. A hemothorax is just bleeding into the chest. Hemo, blood, thorax, chest. Trachea's midline you're not going to have, so you're going to have difficulty breathing, rapid pulse, weak pulses, I guess, if that's even very difficult to assess, weak pulse, and dullness, so you're going to have a dullness to percussion. Also not a good indicator or sign, really. Number 28. A 45-year-old female is found unconscious at the scene of a motor vehicle collision. Her vital signs are 80/40 BP, pulse of 130, and a respiration rate of 30. So in shock. Which of the following is the most likely cause of vital signs? So like I said earlier, the shock index, which is pretty much, is the pulse higher than the systolic number? If the pulse is higher than the systolic number, it means we have a problem in trauma. Pretty much 10 out of 10 times. No, I'd say C, bleeding into the chest, abdomen. Shock, like I said. Cool. Number 29. The cause of a secondary brain injury is, so secondary brain, so primary injury is obviously the assault, so either you get hit by a car or you get hit by a baseball bat. And then what happens afterwards is that if you then stop breathing, or if there's something else that causes a secondary injury like swelling, what's going to cause swelling in the brain or increased pressure in the brain? So the two things are hypoxia and hypotension are the two things that are going to cause secondary injury. Contracoup, which is when the brain knocks forwards and knocks back inside your brain. No coup, no hemorrhage, no, that's primary injury. D, hypoxia. Like I said, hypoxia and hypotension are what kills head injuries. Number 30, which one of the following is a reason to interrupt the initial assessment? Like we discussed, your initial assessment of the ITLS primary and secondary survey, what are we going to interrupt this for? Is for actions that have to happen now that are life-saving. So like chest decompression, airway management, CPR. Cardiac arrest, well, yes, that would stop it. B, multiple open compound fractures, no. C, severe head injury with brain tissue visible, no. Severe shock, no. So 30A, cardiac arrest. So we're going to have to stop. If we go hazards, look for bleeding, C-spine, airway, now they're unconscious, we actually need to go CAB, pulse, no pulse, CPR. Whether CPR is actually indicated for traumatic cardiac arrest is another conversation or for another video. Question number 31. Which of the following is not a desired characteristic of a suction device? What a strange question. I've got no idea. It can be carried in an airway kit with an oxygen cylinder and other airways. So which of them is not a desired character? Okay, yeah, that's fine. It can be hand-powered or battery-powered. Yeah, battery is obviously better unless it's dead. It can generate sufficient suction and volume displacement to remove pieces of food. It can be powered by a portable O2 cylinder, so it is not dependent on battery. I've never seen a suction powered by oxygen cylinders. So I would say probably D. In terms of suctioning food, it's really hard to suction food out of an airway. I have managed a fair amount of airways myself, and trying to suction pieces of meat or sweet potato or broccoli or peas, it actually just gets stuck on the suction device. So you actually just have to like somehow remove them with forceps or something. Suction can't deal with butt nut. You can't suction food. I guess if you have like a really big bore suction, you could probably get away with more, but you still wouldn't be able to do a piece of meat, which everyone who goes into cardiac arrest for whatever reason just had a massive meal. Cool. Question number 32. Which is the most serious early complication of burns from electrical contact? Pain, fluid loss, infection, I guess, but that might be late. So it's 32. 32. So cervical spinal injury, I wouldn't say so. Cardiac arrhythmia, I would say so. Hypovolemic shock, that's a later thing because they lose fluid slowly. D, renal failure, it's also a later thing. So B, 32B, cardiac arrhythmia, because the electric current can put the heart into other rhythms like VF or VT or asystole. Question 33. Which of the following changes is most useful to monitor in a child with a head injury? So A, frequency of vomiting. Vomiting is not a good sign in children with a head injury. B, level of consciousness. That is very, very concerning. C, reflexes. It's going to be a very late sign, I assume. And then sensory exam. D, I'm going to go with 33B because level of consciousness could potentially start dropping. And if they become a bit confused and drowsy and tired, which is probably like if you ask a mom, does the kid seem all right? Does the kid seem normal? The mom will say, well, he seems more tired. He's sleeping more. That's kind of the alarm bells that are going to make me really be concerned. Cool. Question 34. A disorientated 23-year-old male is injured in a motorcycle collision. The patient appears to be intoxicated and does not want medical attention despite a large laceration on his scalp, which is actively bleeding. So he's drunk and he doesn't want help. Treat him as a head injury patient. Well, yes, because if he's had a motorcycle collision, and he's drunk and he has a massive laceration to his scalp, there's a chance that there is head injury, which may make him look drunk. And you cannot rule out a head injury in a drunk patient. So treat him as a head injury. D, wait until the patient loses consciousness and then transport. That's not a good idea. So C, 34C, treat him as a head injury patient because you cannot rule out a head injury in a drunk person. So question number 35. When performing a needle decompression, which of the following is the best anatomical location? So question 35. A, directly over the top of the fifth rib in the anterior axilla line. So that's like this part of the ribs. I'll put a picture up. Directly, which is probably the best place. Directly over the top of the fourth rib in the anterior, under the third rib would be the third intercostal. D, directly over the top of the second rib in the anterior axilla line. No, that's way too high. So the answer is for number 35 is A. So directly over the top of the fifth rib and the anterior axilla line, which is exactly where you put a chest drain in. They're finding that that's the safest place because you actually have the less distance to the pleural cavity, so you're not going to miss it, and you are less likely to hit major organs. Just don't go too low. So that is 35. So now number 36. Which of the following is true regarding trauma in the elderly? Elderly patients are less likely to bleed internally than younger patients. That's not true. Elderly patients have better outcomes following burns than younger patients. That's also not true. Fatal outcomes are more likely in the elderly than in the young. That is true. Motor vehicle collisions are uncommon mechanism of injury. No, I would say that 36C, fatal outcomes are more likely in elderly. So yeah, C. Because they're brittle, they bleed easier, their bones break easier, they don't have the cardiovascular capacity to try and maintain or try and compensate. So they do die easier, unfortunately. 37. Which of the following organs will suffer the least structural damage from a gunshot wound from a rifle? So rifle, big gun, big caliber. I know that the lung is the organ. So let's say spleen, kidney, liver, lung. Yeah, 37 lung, because it is a hollow organ. There is no tissue inside it to be really damaged. If you get hit in a spleen or a kidney or liver, it's a solid organ. There's also more damage in a solid organ because of all of the forces involved in a bullet. Lungs can go clean straight through. Still a problem, but less of it. 38. Which of the following should always be performed prior to transport? Splint all major fractures? No. We can transport with a fracture unsplinted. B, control major external hemorrhage. That has to be fixed straight away. It's hazards, hello help, then it's C for C-spine, then it's C for catastrophic bleeding. Well, it's actually catastrophic bleeding first, then C-spine. Perform ITLS secondary survey? No. Assess vital signs? No. So they aren't wanting you to take blood pressures on scene. They just want you to get into an ambulance as fast as possible and get to hospital. So B, 38B, control major external bleeding. That has to happen before you transport. Everything else can wait. IV lines, blood pressures, vital signs, splinting, tractions in the ambulance. 39. Which of the following distinguishes a tension pneumothorax from a simple pneumothorax? Tachycardia? No, you can have that in both. Shock? A shock will probably distinction. Dyspnea? No, you can have it in both. Anxiety, you can have it in both. So yes, 39B, you can see shock in a tension pneumothorax. You're unlikely to see a shock in a simple pneumothorax, especially if it's just a simple pneumothorax. They can be quite small. Number 40. A 25-year-old female was stabbed in the left arm. She presents with altered mental status, signs of shock. Bleeding is uncontrolled despite direct pressure. You should A, to the left arm. Apply a tourniquet directly over the wound. That's not where you should apply tourniquet. B, elevate the extremity above the level of the heart. That may help if you can. Apply a pressure point, or D, apply a tourniquet proximal to the injury. So proximal is closest to the torso. Yes, number 40. Number 40D, apply tourniquet. So tourniquets go high or die. In the joint is actually the best place. There's less muscle that you need to compress, and the artery can be compressed easier. Number 41. An unresponsive 36-year-old female was involved in a motorcycle collision. Vital signs of blood pressure 170 over 100, that's very high. Pulse 50, very low, so probably swelling brain. Respiration rate is slow, also possible GCS3, which is really bad. I would say she's coning because she has a increased blood pressure, decreased pulse, and probably a irregular respiration. So A, hypovolemia, no. B, increased intracranial pressure, yes. Raised ICP. C, pain and anxiety, no. Spinal cord injury, no. So B, raised ICP will cause an increase in your blood pressure and a decrease in your heart rate. Don't give atropine. It's not going to fix it. We could hyperventilate this patient. 42. A 42-year-old male is involved in a motorcycle collision. Which of the following assessments findings should be managed first? So whatever's more important. A, airway obstruction, very important. Hypertension, very important. External arterial bleeding, the most important. D, open lower leg fracture. I would say 42C, we have to stop the bleeding. If we don't stop the bleeding, doesn't matter if we fix the airway. It's always a conversation, but if the airway is blocked and there's massive external bleeding, we have to fix the external bleeding first and then the airway. If we fix the airway and there's no blood, that was a waste of time. A 43. A 32-year-old male is involved in a motor vehicle collision. The steering wheel is bent. Your assessment reveals present and equal bilateral breath sounds, a rapid and weak radial pulse that disappears upon inspiration. You should expect. So when you breathe in, your pressure in your chest increases, which can decrease your venous return, so probably a tamponade of some sort. Let's see, what, cardiac contusion? No. Cardiac tamponade? Yes. Flail chest? No. Tension pneumo? No, it's not going to happen. So 43B, tamponade. Because when they breathe in, your interthoracic pressure can increase so much, they can put so much more pressure on your heart that can then cause a pulse to disappear. 44, medical director requests application of a second tourniquet. Which of the following is the most appropriate site? So sometimes one tourniquet is not enough, you need to add another one. Distal to the injured site. So that's further away, distal to, I guess, on the other side of the injury, doesn't make sense. Just below the first tourniquet, that probably makes sense. Directly over the first tourniquet, not necessarily. Directly over the wound, no. So yes, 44B would be just below the first tourniquet would be the right place. Not over the same tourniquet, just below the tourniquet. A 35-year-old male, that's number 45. A 35-year-old male is alert and orientated at the scene of a motor vehicle collision, complaining of knee pain and a headache. Your assessment reveals a contusion above the left eye, swelling to the left knee, and unequal pupils. Left is dilated. Vital signs of blood pressure is normal. Pulse is 88 normal. Respiration is normal. So A, alcohol intoxication, no, he's orientated. Cerebral herniation, no. Decreased intracranial pressure. Decreased intracranial pressure. Probably not. Ocular trauma, yeah, it sounds like he has swelling over the left eye. And that's probably why the pupil is having problems. So 45D, ocular trauma. 5 to go. Number 46. You have a patient with an isolated stab wound to the lateral chest, According to the recent study, which of the following procedures should be avoided? Bag valve, mask ventilation, there's no reason you can't do that. Supplementary oxygen, he's probably going to need it. Application of occlusive dressing, that's not a problem. Spinal motion restriction, yes. 36D, so we do not spinal immobilize penetrating trauma unless there is actual damage to the spine or there is neurological fallout. That is because the time it takes to spinal immobilize is actually more detrimental than the benefit of spinal immobilizing and missing the 0.01% of cases that actually need spinal immobilization. Probably won't even make a difference anyway because the injury happens on impact, so primary traumatic insult is when the damage happens, not when we tilt their head left or right. So 46D would be spinal motion restriction, so we don't do that on penetrating trauma unless there is actual neurological fallout already, then we would. So 47, because there's more benefit in getting to hospital quicker than there is to spinal immobilize because it takes time. 47, what is the most common cause of cardiopulmonary arrest in trauma patients? I'd say shock, but let's see what they say. 47, brain injury. That's not going to cause cardiopulmonary arrest. Hypoxia, that will cause cardiopulmonary arrest. Myocardial contusion, not going to cause cardiopulmonary arrest. Ventricular arrhythmia, that can, but that's not common. 47, so I would go with hypoxia B. Hypoxia will eventually lead to cardiopulmonary arrest in trauma patients. 48. A 34-year-old female was struck by a vehicle causing blunt force chest trauma. She is unconscious with gasping respirations, almost no air movement, a rapid thready carotid pulse and flat neck veins. You should. Perform a head tilt. No. She's got a trauma patient. We do a modified jaw thrust. Perform chest thrusts. I don't know why you would do chest thrust. They might be meaning CPR. She's still got a pulse. Yes, you should continue the ITLS Primary Survey. D, provide positive pressure ventilation. You should. She is not moving any air, almost no air, rapid 30 carotid pulse. So she's been struck so hard her brain stopped functioning. You need to be breathing for her. 48D, provide positive pressure ventilation. Number 49. A 34-year-old male is injured in a motor vehicle collision. He is complaining of diffused abdominal tenderness. Vital signs are 100/60, pulse of 120, respiration rate of 28, and shallow. You should. So pulse is above systolic, possibly shock. You should administer sufficient intravenous fluid to maintain peripheral pulses. You should obtain his blood sugar. It's probably not what needs to happen straight away. Complete spinal motion restriction, start ventilating as needed, transport immediately. Yeah, you would probably need to put him into spinal motion restriction depending on how bad the collision is and if you can clearly see his spine, it depends. Start ventilation as needed. He doesn't need ventilations, he's breathing. It doesn't give you much information. Administer intravenous fluid to maintain a 130 millimeters of Hg systolic blood pressure. No. So I would administer sufficient intravenous fluids to maintain a peripheral pulse because we want to allow, remember, a permissive hypotension. So a systolic of above 90 or a MAP of 65, number 50. An unresponsive 52-year-old male is struck in the head by the bucket of a crane, so that big thing that swings. Vital signs are BP of 134/80, pulse 88, respirations of 8. So pulse is below the systolic, so we're probably not looking at shock right now. Patient should be ventilated at a rate of. So he's breathing a bit slow. Pulse is normal, blood pressure is normal, he's unresponsive. So I would probably say he needs to be ventilated like 10. So A is 8 to 10, B 12 to 40, C 18 to 20, D 20 to 24. So I think this is a similar question that's been asked already. We're going to just ventilate him normally. So 8 to 10 would be fine. If he had raised ICP, or if he was coning, or he was posturing, then we could obviously hyperventilate him at 20. But that is not what's happening. So A, 8 to 10. 8 to 10 per minute. Yeah, I hope this was of some sort of use. I know it's been a long video, but yeah, if you have any questions, if you want to discuss any of the things I said, if you disagree with something I said, I'd love to hear about it. Let's talk about some literature in the comments. That would be awesome. If this was useful and you'd like me to do this to more tests and more things like that, or if you just thought that this was just really long and boring, I'd also love to know. So guys, thank you for your time. I appreciate it, and stay well and stay safe, and I'll see you again in the next video. Bye for now.